All right, I'd like to introduce Emily Trittschuh. Dr. Trittschuh is a clinical neuropsychologist and the Associate Director of the Education and Evaluation Unit with the VA Puget Sound Healthcare Systems Geriatric Research, Education, and Clinical Center, or GRECC. She's also a professor in the Department of Psychiatry and Behavioral Sciences at the UW School of Medicine. She has specialized in neurodegenerative disease and geriatrics throughout her career, tremendous expertise. She's particularly interested in strategies to promote brain health during aging, and she's developed psychoeducation programming and educational materials towards this goal. Since joining the VA, she's developed additional and complementary interests in the care of older veterans with PTSD and cognitive concerns. And today she's going to be talking with us about age-friendly healthcare mentation.
Thank you so much, Dr. Cochran, for having me again. Today, I will be speaking about age-friendly healthcare and mentation. I guess I can just bop right past this title slide. In terms of disclosures and acknowledgments, I have no financial disclosures. It is always important to remind you all that the views and opinions that I will be presenting are they're my own and should not be taken to reflect either the U.S. Department of Veterans Affairs or the University of Washington. I have a colleague, some of this talk is part of a talk I developed a number of years ago, but a couple years ago, a colleague, Beth Hogans, and I developed a mentation module for a national VA allied health geriatrics core curriculum, and I've stolen a couple of the slides that she did for that. So I want to acknowledge that as well. Here we are. I realize this series has grown so much. So I hope any of you who are not within the Northwest Geriatrics region or the VA Vision 20 region are not offended by me just pulling these numbers. But it's just a little microcosm of what's happened across the United States. And that is that we need to remember we have an aging population. And thus far, our estimates have always ended up being underestimates, although sometimes not dramatically so. Regardless, though, the number of adults age 65 and older is growing, and we need to think about how to take care of this increasing and changing demographic. Oh, see, here's where I discover that I have something covering up my notes. Let me just move that up. So we're always going to have need for individuals across healthcare disciplines who are geriatric specialists, right? That's one way to take care of an increasing and changing aging demographic. However, that's not going to meet the need, not by a long shot, even if we continue to do the great efforts we're already doing to develop more individuals, perhaps such as yourselves, who will get additional expertise in geriatrics. So who next might carry the load? Well, you might think that it's going to fall on primary care providers, and they will carry much of the load. They do already. However, with the numbers of folks that need to be seen and the time limits on encounters, this is not going to meet the need to care for older folks either. So what we call here at the VA a PACT team, the VA is where I provide my clinical care, even though I have affiliation with the University of Washington. PACT team stands for Patient Aligned Care Team. So yes, there's a primary care provider as part of that team, but critically important are all the other members of the team, whether that the composition of those teams can vary a little bit from place to place. You might think about your care setting, but often includes some sort of an administrative assistant who typically does scheduling, maybe someone who answers the phones. These folks are really important. RNs, social workers, psychologists, various like occupational, physical, speech language therapists. All these folks come together and can really provide that supportive team that can address mentation challenges in older adults. So I hope that by the end of the talk, you're going to really agree with me that given the significant consequences of declines that can occur in mentation in aging, there really needs to be a paradigm shift such that top disorders that affect mentation are a regular part of the workup and always part of the diagnostic differential for aging patients. And then, of course, if I haven't showed my cards yet enough, I'm a firm believer that team approach is the best approach, and that is something that's a useful part of any clinical dynamic you're in, is helping everyone to feel invested in healthcare, whether they're doing the patient hands-on direct delivery in the moment or even outside that moment. All right. Again, for 2025, we're kicking off this ADRD series with the talk on mentation. I'm thrilled again to be doing it, so thank you. I'd like to just do one more touch, though, on some of these things that Dr. Cochran brought up. You know, we need to think about the entire series in the greater context of aging and healthcare. I wonder, you don't have to out yourselves by putting anything in the chat, but I'd be curious how many of you had heard of the 4Ms before the introduction today. I'm finding in my talks that I give, more and more people are already familiar with age-friendly healthcare concepts and systems, as well as the 4Ms. These are the pillars to create the age-friendly healthcare setting. It's really meant to be a holistic framework. I, of course, as a neuropsychologist by training, care the most about mentation, but that does not mean that these other portions are not important. Now, my bias is, though, is that I do think that mentation makes sense to have here at the bottom of this quadrant because in many ways, mentation is a foundation that is necessary for folks to remain independent in aging in these other areas as well. If we think about medications, the ability to take them properly, getting refills on time, those are reliant upon mentation. Conversely, side effects or direct effects on cognition due to medications or polypharmacy are increasingly common, especially in aging. If you look at mobility, that might at first seem less connected to mentation. However, if you think about someone who's had some mobility challenges, they usually have to learn new adaptations, new routines for safety to be able to continue to maintain independence. And those new routines, new behaviors are really quite reliant upon mentation. In addition, reduced mobility can have a conversely negative effect on mentation, such that if someone has a limited ability to get out and about, they might have reduced social connectedness, which is its own independent risk factor for both depression and for dementia. At the top is the what matters. That's always got to be at the forefront for us. And veterans at really many stages of cognitive ability can express what matters to them so that we can align our care to their specific health outcome goals. However, as you can imagine, if we don't ask about this, during typical mentation or maybe mild changes to mentation, if folks start to have more of a moderate or severe dementia, that is going to limit their ability to share with us at the moment what matters. So it's really important that we are always trying to think about that person in front of us and align our care and recommendation to actually what's important to them, what are their values. Let's see, this slide really just was going to hit on some of my objectives. I'm going to jump ahead. So in terms of mentation, one thing that I think sometimes gets forgotten, especially by people like me, neuropsychologists, is that mentation comprises both cognitive function when we think of these like memory and attention functions, as well as mental health, mood, and other mental health conditions. It includes the 3 Ds of aging, which I'll be spending a bit of time on today. The 3 Ds of aging are delirium, depression, and dementia. Within this, though, we do need to remember to think about, well, what are normative, maybe what we call typical changes in mentation that one might see in aging. But we also want to be on the lookout for warning signs, red flags for changes in either cognition and or mood. Also, at the end of the day, we always want to be circling around to independence in daily function and how does current mentation or projected mentation either support or get in the way of that independence for the people we're working with. All right, typical cognitive aging. I try to emphasize typical here, despite the fact that I will mess up at some point in the talk probably and talk about normal aging. I like to say typical instead of normal because there's such heterogeneity in people's abilities, and implying that something is normal or abnormal to me is kind of extremes, and also under normal is pretty vague. So let's think about more typical cognitive aging. During typical cognitive aging, folks are expected to retain their own autobiographical memories. There's no reason people should not be able to recall well-learned information. That would be like facts, like Paris is the capital of France. Also, people are expected to still do well with procedural memories. How do you brush your teeth? How do you use the microwave? As well as expectations of pretty typical emotional processing. And that would mean typical emotional processing for them as adults. What you might see, though, is some decreased encoding of new memories. People might be a little slower to learn new tasks, perhaps need a little more repetition. There can also be some decreased working memory, which sometimes we call sort of multitasking, or being able to manipulate information in our minds. Maybe it's more difficult to juggle quite so many things at once. And also, there's definitely sort of an inevitable in I'm going to get tripped up here this afternoon on that one. But processing speed does seem to always slow down, and folks might be a little slower to respond to novel situations. So here's a graphic that shows cognitive data pulled from individuals across the decades over time. The main take-home message here is not to be able to read all the tiny print or to know all the different tests, but to know that these green shades here, which start up here and then come on down to the 80s, are tests that get at speed of processing. And then working memory, the grays also are up here. Blues, new learning and memory, also have a bit of a decline over time, whereas a more knowledge and wisdom and experiential information, sort of what they've lumped as world knowledge here, actually seems to continue to go up for much of the lifespan, maybe starting to level out a little bit in one's 50s and beyond. I'm thinking that some of you may have noticed that these downward trends, especially for processing speed, actually start in one's 20s and 30s. I would say thank goodness then for this increase in experience and knowledge that kind of balances it out. I do think that some of those quote unquote worried well that we hear from in clinic who are really young, who are in their 50s or early 60s, may just, and especially if you evaluate them and they really don't have any objective notable changes that are concerning, it can just be that they're a little bit more hyper aware of this crossover period where some skills are no longer increasing and they're noticing the losses in some areas a little bit. These are subtle differences, though. This may look like a marked decline, but overall, these are subtle changes. Quick knowledge check. If we had more time, I would go over this in detail and query the group, but maybe just make a little mental note to yourself as we go through here as to whether the following are A, likely age-related, or B, are clear red flags for maybe something more concerning. If someone can't recall the major lives of their own story, that would be a clear red flag, right? Learning new tasks more slowly, maybe having a little trouble figuring out how to use that new smartphone. That is actually A, likely age-related. Can't remember well-learned facts like George Washington was the first president. That would be a red flag. Having trouble with multitasking, maybe being able to carry out a conversation while having to figure out the check at a restaurant in their head. That's a problem for me at any age, and it is definitely more likely age-related than being a red flag. Someone who can't describe steps in a common task like how to mail a letter. That's pretty concerning. That's a red flag. Being a bit slower to respond to new information, needing extra time to process details, more likely to be age-related. If someone loses track of the emotional tone of an interaction and seems very detached and disconnected, that's actually probably a red flag. So we wouldn't care so much about typical changes if it weren't that some changes are not typical in aging. So as you can see here, these green lines, everybody, some people hold steadier over time. Others maybe show a little bit of normal aging, typical changing decline over their increasing age. However, there are other folks who do start to show greater changes, especially in one or more areas of thinking, that start to become a concern, whether it's to them or maybe only to the people that are close to them. However, they're still intact and independent for taking care of their own activities of daily living. If they're tested, if they're evaluated, this might be an indication that they have mild cognitive impairment. We care about mild cognitive impairment because it can be a prodromal state for those that go on to develop dementia. Dementia is where that cognitive impairment has become more notable, and while it's pretty different between individuals, it's somehow tipped over for them to the point where it's interfering with their everyday abilities. People have different thresholds for when cognitive impairment will start to impact their daily living. This is sort of a flexible thing, but as we know, dementia progresses from mild to moderate on to severe stages. We do not have treatments for dementia right now. So, just a quick touch on mental health here, because I think it really can affect thinking more often than we expect. I'll talk mostly about depression today, but never forget that anxiety can really get in the way of thinking a lot, right? It can impair sleep, it boosts the stress responses, it can have folks mentally preoccupied with things other than their surroundings. It can cause people to detach. A lot of this also occurs in post-traumatic stress disorder, but even at a greater level. In this case, folks might even experience emotional numbing, intrusive memories, and they may actually suffer from great estrangement. Also, older adults are not immune from having substance use disorders. So keeping in mind that these folks, whether it's a recurrence of a past issue, a new issue, it's definitely important to query for substance use in all ages. So I'll be hammering this home. Mentation in all of its forms can really have an impact on functional independence. It should hopefully have a positive impact on functional independence. It's essential for behaviors here on the left, like making it to healthcare appointments, adhering to treatment plans, managing your own needs, paying bills, navigating transportation. But similarly, mental health is also important for functional independence. People who are suffering from mental health disorders may have trouble with self care, making good choices, maintaining those supportive, positive relationships, as well as being able to anticipate future needs and avoiding certain conflicts as well. Well, here are some things I've heard in clinic and that you perhaps have heard in clinic as well. Things like I can't focus, low energy. I've definitely had someone say my husband's selective attention is worse. He doesn't listen to me at all anymore. I couldn't find my car in the parking lot. Perhaps more worrisome would be someone saying that you didn't tell me to increase one of my medications and stop taking another. When we think about mentation, though, these are really just red flags. They don't actually give us any specific disorders. In fact, they could be markers of depression, delirium, or dementia, or even more than one of these. So let's talk quickly about some of the Ds. I'll touch on dementia first because this is the greatest fear for individuals is that their mental changes could be a marker of dementia. Dementia is a decline in some aspect of cognitive function and or behavior. It needs to have these four critical components though. If one of these are missing, then the likelihood that what you're seeing clinically is dementia is lessened, right? It needs to be significant, meaning that the changes are having functional consequences and losses of independence. It needs to be chronic. Dementia doesn't get better. People don't have a really bad year and then have a good year and then go down a little bit again and then get better again. There's typically an insidious onset that's slow and a progressive course. Often folks may have an event that they think is when they first notice problems, but if you can query a little bit more, it's more that they really realize that it was not just a little glitch at that time, not that it started abruptly like that. Also, it needs to be a loss. These need to be new impairments, not lifelong. If someone has always had a reading disability and they're having trouble reading, that's not a new impairment. I work with a lot of veterans and maybe they've had head injuries or a stroke at some point in their life. They've often then established a new baseline cognitively after those events. I then am looking at that baseline for any new additional impairments, not holding those impairments from those known events as the reason I would call them. I would never then say that they have dementia because of that. And at the end of the day, dementia is based on some sort of structural damage and change in the brain. It can be vascular changes, it can be protein depositions, but at the end of the day, those changes in the brain are causing our workhorses of the brain to die, the neurons to die, which affects our thinking abilities. So what did I hear? Dementia is not delirium. It's not depression. These can overlap, but they are also independent syndromes. We have to be careful that if someone's having a number of sensory deficits, whether they're having trouble with vision and hearing, or maybe they have communication problems due to stroke and a resultant aphasia, that we are not then somehow labeling that dementia. Also, which should be super clear, is that dementia is not typical aging. So there are many different types of dementia. Here's just a few different clinical dementia syndromes. I'll highlight here. Alzheimer's in adults over 65 is the most prevalent cause of dementia. And here's a graphic I have kind of reminding us all that dementia is a clinical syndrome. It's an umbrella term, and we apply it when we see a clinical syndrome that meets those four important criteria I highlighted earlier. And we presume that it's based upon neurodegenerative disease in the brain. We often can see markers of that neurodegenerative disease in vivo, say with imaging, brain imaging that shows atrophy, or vascular changes that show up on imaging. As well, there are some blood tests being developed. There are PET scans that can show changes in metabolism and even some protein deposition that also supports then that the dementia clinical syndrome might be due to neurodegenerative disease. I mentioned here Alzheimer's disease is the most common prevalent cause of dementia in older adults, presumed to be based on Alzheimer's disease pathology in the brain. Vascular dementia is kind of a close second there and is caused by cerebrovascular disease. Sometimes those changes are abrupt, but other times they're very subtle due to microischemic changes over time. Another third most prevalent cause is Lewy body dementia, which is caused by Lewy body disease. I have these overlapping here because depending on your patient, they may have, and they've been diagnosed with a dementia, they may have Alzheimer's disease pathology in their brain alone, but it's also really common that they may also have some cerebrovascular disease as well, and maybe even there's an overlap with Lewy body disease. This is what makes it tricky and why some cases do go on for specialty evaluation because they're not so clearly one cause or the other. Now, an additional challenge and one that at the front lines really hopefully gets addressed is the fact that there's actually a lot of things that can mimic dementia. I kind of lumped these into sort of toxic metabolic causes, whether that's due to polypharmacy, maybe there's a B12 deficiency, hypothyroidism can cause some mild cognitive changes, but especially things like impaired liver or kidney function. There's systemic illnesses, pulmonary disease, and UTI to meningitis types of infections that can very much mimic a dementia. My other category is perhaps the one that I see the most, which is depression or PTSD flares that essentially are mimicking a dementia. Perhaps chronic sleep apnea that's either not been diagnosed or is not being treated. That to me in my clinic often can look a lot like early mild Alzheimer's disease type dementia. Also, just stress, and then things like alcohol, drugs, other conditions like that. So some of these are not very treatable, but if identified, can be treated and or reversed sometimes. However, it is possible that that may not fully reverse the cognitive symptoms. So these are folks, even if we find a cause like this, that we really want to pay a lot of attention to and follow over time. In fact, a lot of these things, such as the UTI or perhaps acute drug use, can actually cause a delirium. So delirium is one of our other Ds. There's all sorts of terms that used to get used for this. I feel like people have settled on delirium pretty consistently now, and I actually do appreciate that. Words matter. It's considered to be a medical condition. Delirium more often has a rapid onset, and the deficits are usually quite notable in attention and concentration. Also notable is there can be a real waxing and waning of mental status. You can talk to your loved one or a patient at the beginning of the hour, and by the end of the hour, the nurses are calling because they're pulling lines out, or your loved one is agitated and has left the house without dressing appropriately for the weather. They are typically and often caused by infections, medications, maybe metabolic abnormalities. Those are some of the top causes. A challenge can be, especially in older adults, that changes in mental status and mentation can precede objective signs of illness. And also, delirium is often under-recognized, partially because of this, but also partially just because of lack of awareness. I recommend, I know it's an older article now, but this 2014 Lancet article by Inui, Westendorp, and Szynski, I'm not sure I pronounced that correctly, is a really nice review. Sharon Inui is a Boston-based delirium research guru, so anything that she's written on delirium, if you're interested, is worth reading. What delirium is not, though, is insignificant. Work by many authors over a couple decades now has showed that those who experience a delirium have increased risk for mortality when followed not just for 6 more months, but as long as 2 years later. Also, delirium is not a dementia. I think you've kind of seen there's typically a slower onset dementia, in dementia, slower decline, maybe some fluctuations, but nothing waxing and waning on an hour-by-hour basis. Delirium is definitely not rapidly resolving in older adults, especially when the cause is corrected. This could be really challenging when beds availability on a unit is tight and people are trying to be discharged perhaps before their delirium has fully resolved, but because, say, the UTI is now treated. And thinking about what the care disposition will be for an individual is pretty important. Normal aging. That's not delirium. This one seems pretty obvious, right? So, what are some risk factors for delirium? Well, hospitalization sure is one of the biggest risk factors for delirium. Many studies, and especially this review and meta-analysis done in 2014, have shown that delirium affects easily up to 40%. When they, in this particular review meta-analysis, looked at the pooled analysis risk factors, they found that folks with dementia, folks who had had an illness of some severity, maybe had visual impairment, urinary catheterization, low albumin, and also longer lengths of hospital stay were those that were most likely to develop a delirium. A slightly more recent study that I thought had just a really impressive sample size of over 560 looked at the risk factors in a hip fracture hospital sample and found some overlap in terms of those risk factors. They did find that increased age alone was an independent risk factor, in addition to a couple of these others. Also, amount if someone had to have blood transfusions, and other markers like that were identified. So, if we're trying to recognize a delirium, first of all, it's typically attention problems, confusion that develop over days or usually at most weeks. There's trouble with attention, focus, and concentration. I mentioned waxing and waning. There are also often very highly fluctuating sleep disturbances. People may be somnolent during the day. They are wide awake at night, maybe even agitated. I highlight here right in the middle this hyperactive agitated state versus a hypoactive sedated state because kind of what gets thought of, especially if you work on an inpatient setting or in an emergency room setting, is you usually see the hyperactive folks, the folks that are agitated, maybe even are brought in by the police. What you don't get recognized as quickly are those that are in a hypoactive state and may seem very sedated. So, keeping an eye out for unusual sedation is really important. Sometimes people who have delirium are experiencing hallucinations. They may even be paranoid. And I mentioned the somnolence here. Sleep is highly disrupted. Okay. I did just want to highlight that when delirium comes up in different settings, there may be additional demands upon the staff in those settings. And this is really important. And I just always want to highlight that an outpatient clinic. This may be a setting where someone with an acute delirium cannot really be handled and they need to go to the emergency department. But I also want to highlight on the outpatient clinic side, that's where you're most often to see people for that first visit back post-discharge from the hospital. And I would very much be on the lookout for a delirium or a subacute delirium in these individuals because that's a dangerous time for folks. All right, let's talk about depression, my third big D of aging and mentation. Depression is complicated, right? It can be this combination of psychological, bodily symptoms. I list a bunch of things here. Not everyone experiences everything on this list, but it's unusual that someone isn't experiencing multiples of these. Depression is not just a bad day, a week, or a month. We all have those at any age. We all experience grief with loss, right? And depending on these losses or maybe a new medical illness, we may have adjustment periods, and those can go through their normal courses. However, sometimes they can be prolonged adjustments or prolonged grief, and that's where we start to get more worried about a depressive episode. It's important to recognize that depression alone should never be referred to as dementia. It's not a cause of dementia. The term pseudo dementia is very outdated. I personally really dislike it. It doesn't do dementia do justice, and it definitely doesn't do depression do justice, because depression is not untreatable in older adults. Uh, there are so many different types of therapies, whether it's pharmacotherapies or psychotherapies, that we really should always be trying to address depression. I have this little box on the right just to think about normative mental health and aging, and really across the lifespan as well. But sometimes people forget that, just because you're not a teenager anymore doesn't mean that you might not experience a little rebellion if you're told that you have a new medical problem and you're suddenly being told you should take a whole bunch of new medications or adjust all your preferred behaviors, right? So really trying to work with people, find out what matters to them, and then work with that in trying to develop new healthy habits. Okay, for recognizing depression, it's tricky because sometimes in some individuals, it kind of presents as some non-specific physical symptoms that could be like fatigue, increased reporting of pain that seems out of scope with the physical injury or whatever the cause might be, gastrointestinal problems. There are some studies that have suggested that older patients might be less likely than younger patients to admit to being depressed. We all know that depression across all ages can be stigmatized. I personally have found that it's important to try to ask about mental health symptoms in multiple modalities. Maybe I could get a very different response if I ask, "Are you depressed?" in the first 2 minutes of a brand new encounter with someone than I would if I waited until we'd worked together for maybe a half an hour. And then I started asking about how is their mood doing? How have they been feeling, right? There's also asking in writing is something I've liked doing in addition to the verbal questions. Also, think about who the audience is when you ask about depression. I've had some people who did not want to share their low mood in front of a loved one because they felt they needed to protect them from that. So, making sure that there's multiple opportunities for people to share how they're feeling. I also think that we have to learn how to use different words, meaning sometimes people can say they feel blue. Maybe apathy is their primary symptom. Depressed is a word that not too many people endorse unless they've previously been diagnosed with depression. Okay, depression in older adults. There are studies that say that as many as 10% of adults seen in primary care settings have clinically significant depression. Similar studies also found, though, that only 10% of those individuals receiving a diagnosis of depression were actually getting treatment. This is complicated. Were they offered treatment and they did not accept it? We don't know. But it definitely tells us that depression is important, it's prevalent, and it is undertreated. There are all sorts of ways. I mentioned, pharmacotherapy, psychotherapy treatments for depression in older adults, but there's a lot of research out there that suggests that behavioral activation can really have impressive results to reduce depressive symptoms. So consider that even as a place to start if someone's really hesitant to a more traditional therapy. Uh, Older and younger adults do show good responses to different types of therapy, psycho and pharmacotherapy. Sometimes both is the best option, but there may be situations where one or the other is better for a particular individual. I have this slide about antidepressants commonly used to treat late life depression. I'm not promoting it. I'm not a prescriber, but it was a nice article from about, gosh, it's about 10 years old as well. But it did remind people that there are certain antidepressants that are typically looked at first as a frontline treatment in late life depression, a couple of the SSRIs. But I bring it up more than recommending any kind of particular medication as a reminder that you shouldn't hesitate to offer this or to think about it. On the other hand, though, you want to stay up to date with things like the AGS's Beers criteria, which is a tool that's meant to assist healthcare providers when you're thinking about medication safety in older adults. There are certain medications used for mood that have been shown to have more negative effects in older adults than in younger adults. So always referencing that. The most recent criteria, I believe, is this 2023 version, and it's easy to find online. I highly recommend checking it out. Depression in older adults is important to monitor. You know, I mentioned delirium during hospitalization or during post-hospitalization, but also depression can affect people as well. Cognitive impairment has been shown to possibly show a less robust response to antidepressants, which is sometimes why multiple ways of trying to address the problem are important. Behavioral activation sometimes being a really, really good second line. It is also important to monitor for cognitive decline in folks with, especially with a new onset of depression in later years, because it can be a red flag for preclinical dementia. I'll talk a little bit more about this in my talk later this series. I'm super excited. I get to give a talk on dementia prevention and healthy brain aging in February. But I'll talk about how depression is a bidirectional risk factor for dementia. It both can be a risk factor in terms of increasing chances of developing dementia, but it also can be an early symptom of dementia. We always have to keep in mind suicide considerations. Suicide and depression are not lockstep with each other. Some people can express very mild depression but have high suicidality and vice versa. But we always care about suicide. It is not uncommon that people who are experiencing depression changes in mentation may not be thinking about the future the way that they would if they were not depressed, and they may make decisions that they would not have otherwise in terms of their life. So suicide rates can be higher in older adults. There are also certain areas of the country where they can be higher in veterans, cisgender males, as well as white and Native American peoples. Here is sort of a table comparing some of the common features of these three, as well as things that might be considered hallmarks. I'm not going to read through all of this. You'll have the slides. I bet you're like, oh, great, it's black and white, so easy to distinguish. Unfortunately, there's a lot of overlap between these syndromes, as I've highlighted already. Here are just a few different numbers on the overlap of two or more of these across different settings. I want to jump ahead though, because I want to bring up a case example. This is, we'll call him Joseph. Of course, this is not a real veteran. This is sort of an amalgamation of some patients that I have seen. He's a 66-year-old cisgender male veteran who is divorced for 2 years now from his second wife. It was a shorter marriage, less than 5 years. He's actually brand new to your primary care clinic, and he moved here to be closer to his daughter. Currently, he's living independently in an apartment. However, his daughter brought him into the primary care clinic because, as she said, he just sits around all day and he forgets what I tell him. He has a premorbid history of diabetes and hypertension, but with historically very good control. So we're in a sort of interesting situation here where the veteran is really not endorsing much. He's not the reason that he's in the clinic. He didn't want to come in. It's really just to make his daughter happy / to get her to stop bugging him. But she doesn't really have a lot of collateral info. He's newly living near her. But regardless, if we don't have like longstanding collateral info, we can acknowledge that we are very lucky to have a connected and invested close family member nearby. So here's what I just had there. So upon workup in clinic, it's discovered that while he and she thought he, say that he's had historically good control, his current blood pressure and his glucose are really far out of range. You might be asking yourself, is he taking his medications? Insulin is prescribed. And I say this because I have seen a situation where there was sort of just a knee-jerk reaction to increase medications and put someone on insulin. You could imagine that if he hadn't actually been taking his medications as prescribed, that could be a reason for these numbers, and that actually increasing the medications has the potential to create more of a problem for Joseph, right? He does endorse, when you ask him a little bit more, that he is actually really missing his second wife, and he is sad because he does not have any friends. Lastly, you as a clinician are really picking up that he seems disengaged and does not seem cognitively sharp. So, what are maybe the next steps? Well, I hope you've seen the red flags here, right? And that you want to do some more workup, thinking about identification and screening tools. This is a little pocket card called the 3Ds card, a delirium, dementia, depression assessment guide that was created by a group that I currently am chairing, the Aging and Cognition Education Work Group for the VA. We did an original version of this pocket card back in 2011, and it was so popular. We did an update in 2014, and now we're currently working with the 2011 update. So it's just brief information and brief tools on all three conditions. I'll step through it a little bit. So for delirium, it has some of the information on the CAM, which is the confusion assessment method, and some really brief pointers. However, we did, recognizing that this was a little thin, especially on the outpatient side where there aren't as many materials. Our group actually recently developed a specific independent card, the Delirium Reference Guide, that goes into more detail. I'm proud to say it also talks a bit more about management and prevention and mentions a couple different approaches to that. In addition, it contains the BCAM, the brief CAM, the brief confusion assessment method, which I love this flow chart that was developed at Vanderbilt University and we were able to reproduce with permission that really helps give you a quick and dirty, fast way to think about whether the types of mentation changes that might indicate delirium are present. One component of it is the Modified Richmond Agitation and Sedation Scale. The original RAS was actually developed to measure levels of sedation or agitation in ICUs, but the MRAS is meant to be used in non-ICU settings. And then you can see here a 0 would be what we're all hopefully at. I hope not too many of you are at the -1 drowsy level. Anything that's much beyond alert and calm, +1 restless, or -1 drowsy starts to get a little concerning, right? You're getting up into agitated, very agitated, combative, sedated, moderately sedated, deep sedation, or perhaps even unarousable. And it's a useful tool. It's very simple. You can use this to track people also at varying time points during the course of a delirium. So in working up a delirium, it's important to try to use multiple sources of information to make sure it's not just someone's baseline. You want to consider the broad differential. This is an acronym called I Watch Death, and I know that not everyone loves this because it is so negative sounding. However, it'll stick with you. I learned it first when I was in grad school and working with med students, and this is what they were using to basically track and check off all the different things they needed to rule out, basically when trying to work up a delirium to find the cause. In Joseph's case, we really didn't have reason to think that he was delirious, but it's useful to keep in mind that situations could change and that he might have a higher risk than some other individuals for delirium. So let's switch gears and talk about depression. I want to emphasize, you do not need to be a mental health professional to ask about potential symptoms of depression. I want everyone, whether it's with people around you in your personal life, to have tools that you can use to guide you if you ask about these, just on the off chance someone does say, yeah, actually, I'm really depressed. But in a medical setting, we usually have a lot of tools and scaffolding around us to help support us and ways to do warm handoffs, even if you are not a mental health care professional. Screening for depression is covered by Medicare Part B, so you can always add on to a visit, have people stick around, make this part of a regular visit. There are many tools out there. The VA uses the PHQ-2, the PHQ-9 in primary care. These are well validated, free. They're commonly used. I personally, in my neuropsychological evaluations, use the Geriatric Depression Scale, the full 30-item version, but even the 15-item version is pretty nice. At the VA, we are also required to do suicide screening and severity rating in all individuals as well, given that these two things don't always go hand in hand. We want to screen for that. Quickly looking at the PHQ-2, it's very quick. And you're basically just asking someone over the past 2 weeks, how often have you been bothered by these two problems? Either essentially, number one is anhedonia or just feeling down, depressed, or hopeless. I personally feel like if you're going to take the time to do the PHQ-2, yeah, might as well just do the PHQ-9 because I do think this gets at a little bit more breadth of potential symptoms. And it also gives people the chance to want to open up to you more. 2 quick questions, I can pretend everything's fine. That's not too hard. But taking a couple more minutes and being asked about some of these other quote unquote more neutral things might make people open up a little bit more. In Joseph's case, his workup was positive on the PHQ-9. He definitely had evidence that he was potentially experiencing depression. The good news was like item number 9, thinking he was better off dead or wanting to hurt himself was negative. I would have, of course, however, still do the Columbia suicide severity risk screening. In Joseph's case, though, he had he denied any current suicidal ideation and did not endorse having experienced any in the past. Okay, dementia. I highly recommend the use of the red flags method. Depending on your setting and your billing sort of structure, your reimbursement structure, you may be required to do some sort of a dementia screen, whether it's a cognitive test or other, in everybody over a certain age. At the VA, we are not supposed to do this unless there is some sort of a red flag. I'll tell you what, though, I feel like I could walk into almost any clinic at the VA, grab 10 veterans, and at least 8 of them would have some red flags. So the most important thing here is that if you get a red flag, don't ignore it. It's a great time to, at the very worst, just get a little extra baseline info that can be in the medical record to help guide future providers. And at its best, it can really help catch something early and allow us to address all of the M's and create a very age-friendly healthcare setting for individuals. Okay, so I hope you were reading over these as I was talking. There's just some examples that either providers, the clinicians might notice, or even other staff, non-clinicians, and also the types of things that patients themselves, or maybe even more often their loved ones, might report. So, but what are you going to do with that? I mean, one thing we definitely want to do is see if there is actually any objective changes to thinking or weaknesses in thinking. Probably one of the quickest, and it's definitely a little dirty, is the mini cog. I don't know if you've heard of this. It's only a 5-point screen, and it's the thing I recommend pulling out if you have done your whole visit, you've done all this excellent workup with your patient, and right as they're heading out the door and you have 0 time left, they say, "Oh, yeah, and by the way, I've been having notable problems with my thinking, and I even left the stove on, and I went through a stop sign recently," right? They say something where you're like, "Oh my gosh, we cannot just schedule another appointment. I need to take a time to address this." So this is what I recommend in that situation. It's a quick 3-word encoding, then drawing a clock, and then asking them to recall the words. Only that recall is scored, and 2 points for the clock. The rules for the mini cog clock are pretty strict. They actually have to have a really good quote unquote normal clock. Otherwise, they get 0 points for that. However, you may have noticed, sorry, let me go back 1 second, is that 3 to 5 points may suggest no impairment. So someone could fail the clock, but if they remember all 3 words, they would get 3 points. I'm going to tell you that if they give you a bizarre clock, this one's sort of not bizarre, but it's not quite perfect. If they give you a bizarre clock, please don't just wave them on. There are types of dementia that don't affect memory as the primary, but say may affect executive function or visual spatial function, both things that are needed to draw a normal clock. Other brief cognitive tests, these are things I recommend more if you can do them. They don't take that much time. They're 30 points. They definitely have better sensitivity and specificity, although neither of them has a great specificity. So I recommend the SLUMS, which is the St. Louis University Mental Status Examination. It's used frequently at the VA, probably because it's free. And then also the Montreal Cognitive Assessment is a really terrific one that probably has the greatest sensitivity and specificity of these 30-point examples. Some people use the Blessed Orientation, mental memory and concentration tests. I like it, except that it has reverse scoring, and I have found that people often put the scoring in the chart and don't indicate the directionality of the score. And so I've seen some confusion over time from different providers with that. The whole goal of doing these brief cognitive tests is to try to give like an objective number that can be used to sort of follow people over time. And if it's not reliable, then it's just not good data. There's a few other things out there. The Addenbrooke it's developed in Australia, but also has a US version. But really, I love the MoCA. I'm biased. And they have a lot of information on their website. They have demonstrated sensitivity that goes far beyond the traditional MMSE. There's a lot of research that's used the MoCA because they were so open in its utility early on. You can even find that on their website. There's many English versions in case you need to give this repeatedly in a very short period of time. But also they've shown good retest test psychometric properties if you're giving the test even just a month apart of the same measure, the same version. The MoCA comes in many different languages. Of course, if you're going to administer it in a language that you're not fluent in, there you can see how there's some problems with that. It also has a blind, or you could also call it the telephone version. So that works for gives us breadth of individuals we can use it for. There's also a telemedicine version, which is nice as well. The developers do expect or ask that you do training or certification, and this is really just to preserve the standardized method of administration that makes it a reliable and useful tool, right? Okay. The slums is far from perfect, but perfectly acceptable. That's what I tell people about that one. You just use the standard instructions. There are a couple of videos on YouTube that are actually kind of nice. They're like only 8 minutes long, and you can watch someone administer it and go over the items, and it's pretty useful. It's free, and there's no training required, but I really do recommend watching one of the videos if this is not something you're very comfortable with already. It doesn't have, though, the same sort of research sample that it's based on. There's very little follow-up research. I have sympathy for the developers because, of course, they were VA employees like myself, and they probably had absolutely no time to even be developing this in the first place, and they probably ran out of steam for keeping it going. There's really no official adaptation for telephone or telemedicine. However, you can really adapt these things by doing prorating and just making it really clear in your note that how you administered it, what items you did or did not administer, and what your denominator is for the score, right? So don't put in that someone had a score of only 21 when you did it via telephone without saying that the total points possible were 26, right? Because that would be a pretty different interpretation. Okay, what is the utility of brief cognitive tests? Well, I'm sure you can tell right now that I think they're super useful. They can be used to obtain a quick sense of global cognitive function. Sometimes they can pick up on cognitive decline early. And then I think really importantly in some settings is picking up on whether maybe someone does not currently have the capacity to be making medical decisions. That's not necessarily a permanent change, but in certain inpatient settings, it would be really useful. In terms of identifying cognitive decline early, I think I've made it clear that not all cognitive change in aging means there's going to be dementia. And so, given that there's other things that can look like dementia or might just be mild cognitive impairment, sometimes identifying a lower score can be used to help motivate people toward positive behavioral change. Certainly, it can get us going on trying to address any potential reversible influences, treat things like depression, sleep apnea, things like that. Okay, so these cognitive tests, they do have some challenges. They are definitely poor as standalone measures. If you don't have any collateral input and you haven't considered other risk factors, you should not overinterpret a score. They certainly are not diagnostic on their own. There's also times where you have to really think about if your population, the person or the the person that you are doing this with has any diversity factors or other factors that may inhibit or get in the way of sort of interpretation. So I've talked a lot about warning signs and ways to screen cognition, especially the limitations. There's one really important piece of the puzzle. Oh, wait, sorry, really quickly. I forgot to say Joseph Smoka was a 25. So he's right in that gray zone. He is definitely not in the uh-oh range, but he is also not clearly intact. So this is going to be something to think about. But there's one, as I was just starting to say, there's one piece of the workup for him that that I've totally neglected, that would be necessary if we were trying to think about dementia. That is his independence in daily living. I really like the functional activities questionnaire, although there's lots of other instruments out there that ask about activities of daily living, especially these instrumental activities of daily living. But this one I like a lot. It's in our 3Ds pocket card. It asks about writing checks. It just goes across these different categories, even kind of giving very straightforward, simple examples that almost everyone does. I like that it's simple scoring as well. A 3 is what you get for each item if you are totally dependent on others. 2, if you require some assistance. 1, if you have difficulty with it, but you can get it done on your own. And 0 would be either you never did it, but could do it now, or you are able to do it without incident. If you never did it, but a loved one thinks you would have difficulty now, or you think you would have difficulty now, they give that a point of 1. So the cutoff is considered to be 9, which means that you would be essentially dependent in 3+ activities. Joseph's score was a 3, so that means that he is not above the cutoff. It suggests that he does not have any impairments in his independent living such that we should be too concerned. In his case, he has a couple of things that he's been having difficulty with, but does by himself. One of those was traveling around his neighborhood. You can appreciate if he just moved to his new location, that would be harder. And I think the other one was some of the financial things he was having a little bit more difficulty with and wanted his daughter to double check his taxes and whatnot. So always keep in mind, dementia is the diagnosis of exclusion. Okay, I pull in this little cheeky cartoon here where the physician or some provider is looking at an MRI saying, I think we might have found the cause of your sudden memory loss, and looking at the hat pin for Mr. Potato Head, which may be causing a significant brain injury. We always want to think about risk factors that could be causal or at least contributing. The 3D pocket card has one panel that's dedicated to these, but in addition, our group has developed a number of healthy brain aging materials. I think in my talk in February, I'll talk about these and those education materials a bit more. But here are just a few of the things to think about in terms of medical conditions, as well as certain behavioral factors that can both be risk factors for developing dementia, or if they go in the opposite direction, can actually potentially be protective factors. Okay, so I kind of talk about having like a 3Ds action plan. Anybody that you get that has any kind of red flags, whether they're for dementia or any of the 3Ds, any changes in mentation, you really want to just start off the bat by ruling out and gathering data, right? Using those frontline tools, getting some objective markers, good history, maybe blood or usually blood tests. And then depending what you find from that, you may just start monitoring someone. I really don't think anyone is ever completely free from risk after you've done a one-time rule out, right? So you just want to kind of keep this cycle going. Some individuals may have things in the rule out period that suggest more in-depth evaluation is necessary, whether that's maybe a brain scan, maybe in the case of Joseph, a referral to me for a neuropsychological workup. He was kind of in that gray zone, and the depression was a component, but didn't seem sufficient to explain some of the things that I actually saw in terms of testing. So let me jump back to Joseph here then. So we talked about how delirium was ruled out. He actually was amenable to depression treatment, and that was pretty great because he was lonely, but he wasn't able to do what he used to be able to do in the past when he moved to get himself out and about and motivated to meet new people. The dementia component was to be determined. He was referred to me for workup. We got a nice baseline. Of course, I could rule out dementia in the moment because he did not meet criteria. He was still functioning independently, but we did want to follow him over time because on testing, he met criteria for mild cognitive impairment. All right. So, trying to end with a little bit of levity here. Thank you, Gary Larson. I have stolen one of your cartoons for educational purposes only. We've got an aging Superman standing on the windowsill of what appears to be a very high building, looking back at Lois and saying, "Dang, now where was I going?" And we could say this is a red flag, right? Is it potentially dementia, delirium, or depression? We don't know for sure yet. We need to do more. And on that, I will just end by saying thank you so much. We can talk now. I plowed through this pretty fast to make sure that we have time to talk and go over things. You can also reach out to me directly with questions. I've put my University of Washington email as well as my VA email here. If you're at all interested in the 3Ds card or the delirium independent card for outpatient settings, here is the email of our GRECC education nurse who handles those requests. She is actually out for a family member. For care for a family member here coming up starting next week, but that does not mean you shouldn't message her or me. We will back to you. In fact, we plan to do a big mailing at the very end of the month. So we'd be happy to add you, whether it's a small mailing of 20 or a larger mailing of 100. We just need to know the amounts, sort of where you plan to use them, and a mailing address that you can get a box at. So thank you so much for your attention. This is where I can't speak, awkwardly stop sharing and try to see who we have still around.
Well, we have quite a few still around, and thank you so much, Dr. Trittschuh. This was just tremendous. What a great introduction to the series. I do have a couple of questions, and then there may be some coming as people get a chance to think about others. Becky is wondering, what are the different signs of hypoactive delirium as opposed to just exhaustion?
Ooh, that
Great
is
question.
that is a great question. And it is complicated. In someone who, first of all, if someone's exhausted and they are able to be somnolent and sleep for an hour, they should wake up next and seem sharper and more refreshed. The person who is experiencing sedation is unlikely to seem like that. They may briefly seem normal again, but maybe even only for 5 minutes, and they would be unlikely to express that they feel refreshed. Does that make sense? And also with exhaustion, usually there's an identifiable reason why someone's exhausted. Either they've been experiencing and they can vocalize it, insomnia, or really physically been drained due to medical things or other stressors. Yeah, is that helpful?
Yeah, I think so. Lori also said you briefly touched on Parkinson's disease. What correlation do you see with Parkinson's disease and dementia? And what about other movement disorders like ET and dementia?
I don't believe that there is yet a strong literature saying that those with essential tremor are at higher risk for developing dementia. However, but there are sometimes some cognitive patterns seen amongst those with essential tremor in aging of some mild weaknesses in certain areas. That's usually more detectable, though, only with, say, a full neuropsychological evaluation. Parkinson's disease is different in that there are some aspects of thinking that are very commonly part of that syndrome, even in earlier stages. In individuals who are older and those who've had their Parkinson's disease diagnosis for potentially more than 10 years, the rates of Parkinson's disease dementia go up, I believe, as high as 50%. So the challenge with Parkinson's disease is there's a known neuropathology based on the development of Lewy bodies from a protein abnormality. And those changes, those Lewy bodies, increase in the brain over time and in their distribution. So in Parkinson's disease, those start off in the dopamine producing areas of the brain, but eventually are in other areas of the brain, affecting more and more things, not just what dopamine controls. And similarly, like in Lewy body dementia, those Lewy bodies start in cortical areas of the brain and then become further distributed and denser and eventually affect and often cause movement, Parkinson's disease symptoms as well, just not usually the first symptom. So those are very related conditions. Hopefully, or we don't think we have a talk on it this year, but maybe that's something for next year is to really start talking about alpha-synuclein, which is the protein underlying Lewy bodies and the newest advances there.
Really helpful answer as well. We also have a question from Brooke, and Brooke, I appreciate you saying you work for Alzheimer's Association. In order to encourage more of this kind of interaction, if any of you are comfortable sharing your setting and/or your discipline, that would be great. So Brooke is asking, saying that earlier you said there was no treatment for dementia. Did you mean no cure? Because there's treatments for symptoms and new treatments for early stages to slow progression. And of course, as Dr. Trittschuh will probably say, so many more on the horizon.
Well, there's different ways to approach this. If someone's coming from the perspective of the Alzheimer's Association, there's a strong drive within the association to really get behind the anti-amyloid treatments that are FDA approved. Those are those therapeutics. I like to use the term therapeutics for those. I don't think of them as treatments. Those therapeutics have been shown quite definitively to remove amyloid from the brain. However, those individuals do not get better. They decline. They may show less decline over time than the placebo controls. Alzheimer's disease is based on more than one type of pathology. There are neurofibrillary tangles that are a critical component of the disease as well. And the anti-amyloid treatments do not remove the tau deposits from the brain. So I just think that while I'm really excited about some of the advances in the area of Alzheimer's disease, I caution folks, they're not cures and they're technically not treatments because a treatment is meant to help get you better rather than slow decline. And even in this case, it's just tricky. That's a whole nother talk. We got Dr. Thielke, Stephen Thielke, and I talked about it a little bit in one of the talks last year. I am excited though for the future with these different types of treatments that can remove pathology from the brain. You could imagine how in the future, if you could develop something that could remove tau plaques, things that could remove Lewy bodies. I mean, this really could be amazing. That help? And other treatments, other quote unquote treatments, I don't like treatments again, other medications that are out there that are FDA approved are often just, treating symptoms, agitation, meant to try to allow the brain to use the acetylcholine it can still produce more effectively in the case, say, of Aricept. So they have some utility potentially, but again, they're not actually ever found really to improve anyone.
It's an important and thought-provoking distinction,
It's
that's for
tough.
sure.
I could, you don't want to get me going. It's a multi-hour and again, it's a discussion. It's not a lecture because there's many more unknowns than there are knowns.
So, Mary Zeitner was wondering about thoughts on post-COVID effects that might be appearing like a dementia.
What a good question, and one that I think is really, really present in the minds of a lot of researchers. I actually am not engaged in any of the projects that are looking at this at our VA. It's actually our rehab care services that has really gotten into investigating the effects of long COVID because probably the long COVID symptomatology that seems to be out there, while cognition is present for many people, there's so many other areas as well, that I think that given that they have this sort of like multidisciplinary, multi-professional environment, they've sort of taken that on. So sorry. In terms of post-COVID effects appearing like dementia, if you use your dementia rule outs and those criteria that need to be present, that there's a reason to think that there are progressive changes in the brain that are going on, a neurodegenerative condition, this would not meet that criteria. I could say that it might look like a dementia, but if you followed someone over 5 years and they're getting consistently worse over time, I would absolutely be looking for a cause other than COVID in the brain for why that might be happening. And again, instigating all these other rule outs just to be sure.
So Ivan is wondering if you can give an example of or two of poisoning that would mimic dementia.
So interestingly, I don't see many of those patients because I'm not that front line. Um, I typically do my workup after a lot of these very, dramatic reversible poison, kind of causes. One thing I could say though, as an example, and it depends how you want to term poisoning. I did have a veteran come to see me who that really, honestly, if you did the chart review, you were like, wow, this guy seems to have had the onset of potentially a dementia. And the course was shorter. It was only like 6 months. But he came in and he was there was all sorts of little red flags. In gathering history from him finally alone without family members present, I basically discovered that he has was really feeling his age, made new friends down the street who were younger, and he wanted to feel younger like them, and they were doing methamphetamine, and so he started doing drugs with them. And so his presentation was increasingly worse because he was using this substance more and more and acutely affected by it, but then also experiencing withdrawal, only nobody knew and he hadn't told anyone. So again, that's sort of a loose interpretation of poisoning, but I think that's kind of he was intermittently poisoning his body. And nobody else knew that, and thus they were very worried he was developing dementia.
Mm. So Lori said, first of all, thanks so much for this, and that she wished there were more literature and awareness regarding ET. I'm assuming she means essential tremor, since it's 8 times more common than Parkinson's.
Oh wow, I didn't realize it was 8 times more common. Yeah, I do see a slightly biased sample at the VA, right? Because Parkinson's disease is one of the conditions that's been associated with like Agent Orange exposure. So I do think sometimes I see a disproportionate population in some of these areas. Yeah, I do think essential tremor could get more awareness. I'll tell you, and in my decades now, God, it sounds like awful. My decades of being in practice, one thing I would say that I am glad that I've seen a shift in, and maybe you would echo this, is people are no longer calling it benign essential tremor.
Yep.
That to me was so problematic and kind of dismissive. As I think you probably would agree with me, Lori, it can be a devastating condition, and it affects more than sort of the motor symptoms that we just most immediately think of, causing problems due to those motor symptoms. So I agree. I do wish there was more out there, and frankly, more treatment. So this is an interesting thing where I would use the word potential treatment, and that is I do pre-deep brain stimulation evaluations working with neurology here sometimes for both Parkinson's disease and essential tremor. And some of the folks that they've told me anecdotally they see some of the best results from are some of the essential tremor folks.
Mm.
But again, it's not benign, and we like to do a neuropsychological evaluation before they do their decision making, whether to go forward, just to see what the baseline is.
And thanks, Ruth, for letting us know that you're a social work coordinator for the caregiver support program with the VA Medical Center. And
Oh, thank
Becky
you.
also is an APS social worker with DFS and asks, what do you think of the new medication the FDA approved this year?
So you're probably referring to one of those anti-amyloid treatments. Please don't, I have to laugh. I believe lecanemab was the first one that was approved, which is, sorry, there have been three that are approved. Aduhelm was the first one, but that's not used so much. Lecanemab, which I believe the brand name is Leqembi, and then donanemab is the newest one that was approved. I'll leave aducanumab out of it, and lecanemab and donanemab are pretty similar. I think they both are super exciting in terms of research and possibilities for the future. I work in a veteran population, and a challenge for me is that these drugs are not very, not many people potentially could show benefit, or you say, sorry, are good candidates for the treatment. They're very expensive. They are high resource, high burden. I just, I don't know. Yeah, I have questions about whether the FDA approval might have come a little earlier than it should have. But that's a personal opinion. That's why I make that disclaimer at the beginning. I'm a huge believer in trying to get a cure, to develop or real treatments with benefits for people with dementia, especially Alzheimer's disease, because that's where we've made the most progress recently. Um, Maybe I've gone off track here a little bit. I'm happy to have a side conversation as well. I know I'm being recorded right now, so I'm not as you can tell, I'm not paid by any drug companies. I might sound a little bit more enthusiastic if I had a different perspective.
You know, from my perspective, there is so much hope and need and desire for treatment that everyone is paying close attention, and that always brings up controversy. So
Yeah, and the
that's
attention
my
is good. I want to make sure that we continue to, I mean, these are not things that should be thrown out or, that I see no future for. I don't mean it, if I sound negative, I do not mean to sound negative in that manner. Definitely not. And thank you, especially the social work folks here. Um, I yeah, our social work team here is one of the teams that I rely and value my colleagues so much. Even if it's just the things they teach me that then I can use to work with families and veterans themselves. It's really important work.
Well, I also wanted to mention Lisa, who signed on, is an OT with Providence Sound Home Care and works with Teepa Snow and those sorts of things. But it occurred to me when I saw you signing in that OT is so important in these contexts, particularly for movement disorders and essential tremors and that sort of thing. So thank you for being a part of this.
Yeah, I'll add on to that. I think, I talked about the team approach at the beginning, and as a psychologist, a clinical psychologist by licensure and training, whether we call them allied health or associated health professions, I think that when we all work together, that we've really, especially in geriatrics just pulls for this team approach because people have so many levels at which they can, there's intervention potential. And sometimes it's just a little here and a little there that can really lift people up. It's really rare that there's just like in geriatrics that there's just one thing that can be done and should be done, and then everything's better. So I really appreciate that.
And I appreciate everyone participating. We clearly have folks from many different disciplines and a lot of important settings. I think we also have family members and caregivers participating with this series. And so thank you, and please don't hesitate to join in as well as offer questions. We will see you again next week when Dr. Stephen Thelke will talk to us about the whole person in dementia, and have a really nice weekend.
Thank you, everybody. I really appreciate you joining tonight and giving me your time.